Good evening, everyone. Thank you so much for joining us. I'm Laurie-Marie Pisciotta, and I'm the Executive Director of the Mental Health Association of Rhode Island. Tonight will be our second virtual town hall in a series that we are calling Integration for All. This lively panel discussion will focus on the topic of the criminalization of mental illness and how an Olmstead plan could reduce the number of people who are incarcerated with serious mental illness. This event is funded with support from the Rhode Island Foundation, so thank you very much, Rhode Island Foundation. First, a few housekeeping reminders. This event runs from 5 o'clock to 6:30, and the last 30 minutes we will take questions and comments from the audience. Only panelists will be seen, and only panelists have microphones because we had about 100 people register for this event, and that will just keep things running smoothly. If you have a question for one of our panelists, please type it into the question and answer box, the Q&A that you'll see at the bottom of your Zoom screen, instead of putting it into the chat. So again, please write your questions in the Q&A box and not the chat. This event offers closed captioning services for those who need it, and it will be recorded and posted on our website and social media pages in the days to come. After tonight's town hall, please consider what you can do to help the hundreds of vulnerable Rhode Islanders with disabilities who are living on the streets or in prison or in nursing homes. Contact your elected officials and ask them for an Olmstead plan. Consider volunteering at one of these very worthy organizations who are the boots on the ground helping these vulnerable Rhode Islanders. Consider writing a letter to your local newspaper. You have so much more power than you think, and if we work in unison, we can really have a big impact on the system. So I want to begin by giving a little bit of context to this topic and why we're talking about the criminalization of mental illness as it relates to an Olmstead plan. So about 100 years ago, we had really terrible asylums for people with disabilities, particularly those with very serious mental illness. And these asylums had very dismal, inhumane living conditions. Our founder, Clifford Beers, who founded the first mental health association, was actually living in one of those asylums when he started to chronicle all of the abuse that he endured. He published an autobiography called A Mind That Found Itself, and he put out a call to action to deinstitutionalize people and to allow people to live freer, healthier lives in the community. He won the respect of physicians and they joined his cause, and together they actually achieved this dream. And so people were eventually liberated from asylums, and states paid for community mental health centers, psychiatric hospitals, supportive and supervised housing arrangements. Then in 1999, the Supreme Court, the United States Supreme Court, ruled on a case called Olmstead VLC, which found that the segregation of people with disabilities was a violation of the Americans with Disabilities Act. The court said that states have a legal obligation to provide individuals with disability the opportunities to live, work, and study in the least restrictive setting permissible by their particular disabilities. This, of course, necessitates a full continuum of care. On the one hand, you have outpatient services and community mental health centers, and on the far end of that spectrum, you have options like long-term housing and supportive long-term hospitalization, supportive and supervised housing options. So the whole gamut is necessary. And the court also noted that a state could comply with the Americans with Disabilities Act if it had a working, comprehensive, effective plan, sort of a framework for how it would achieve this legal obligation. And so almost all the other states in our country have some type of a plan, an Olmstead plan or something like it. Rhode Island is one of a small handful of states that does not. And so how does an Olmstead plan relate to the criminalization of mental illness? Well, we know that nationally, 15 to 20% of inmates in prisons across the country are there because of untreated serious mental illness and a lack of housing and hospitalization options for them. So in Rhode Island, we have about 400 to 500 inmates who are incarcerated with serious mental illness. And this has become the largest psychiatric institution in the state. Many of these vulnerable men and women have cycled in and out of emergency room departments, hospitals, homeless shelters, and then ultimately end up in jail or prison. So an Olmstead plan would assess the state's ability to meet the unmet needs of these individuals, would put a plan together for what is needed in terms of housing options, community services, and would actually then plan for permanent funding streams to support these options and services for these folks. So that is why we are talking about an Olmstead plan and the criminalization of mental illness today. We have a wonderful panel of guests with us today, and I'm really excited to introduce them. First, we have Dr. Christine Montross. She is a 2015 Guggenheim Fellow in General Nonfiction, an Associate Professor of Psychiatry and Human Development at the Warren Alpert Medical School at Brown University. And she's also a practicing inpatient psychiatrist. She's an award-winning poet and the author of Body of Work, Falling into the Fire, and most recently, her newest book is Waiting for an Echo, The Madness of American Incarceration. So welcome, Dr. Montross. We're very happy to have you here.
Thanks, Laurie-Marie. Happy to be here.
We also have with us tonight Nick Horton. He is the co-executive director at OpenDoors, Rhode Island, where he has helped the agency provide reentry services to and advocate for criminal justice reform since 2004. Mr. Horton founded 9 Yards, which provides long-term intensive reentry support to end the cycle of crime and incarceration, and has helped change Rhode Island laws around court debt-related incarceration, probation revocation, reducing the criminalization of prostitution and marijuana possession, and justice reinvestment. So nice to have you here, Nick. Thank you very much. Megan Clingham is currently the mental health advocate for the state of Rhode Island. Prior to that role, Megan served as public defender for 16 years and gained an understanding that people with mental illness were and are disproportionately represented in the criminal justice system. Megan has spent the last 25 years of her career advocating for a system where people are provided with treatment rather than being criminalized and incarcerated. It's always nice to see you, Megan. Thank you so much for being here tonight.
Thanks, Laurie.
Sarah Martino is Deputy Director at the Center for Health and Justice Transformation at the Miriam Hospital. For the last 5 years, Sarah's work has focused on healthcare transitions for people exiting incarceration. She currently oversees the center's programming and policy work. Welcome, Sarah. Thank you so much for being here. And Brenda McClain is a case manager at OpenDoors, Rhode Island, a certified peer recovery specialist and community health worker. Brenda helps people with criminal records access services and manage their recovery. She is a McNair Scholar at Rhode Island College, where she is completing her bachelor's degree in social work. Brenda, thank you so much for being here. We're grateful to have you. So without further ado, I would like to read an excerpt from Dr. Montross's book, unless Dr. Montross, you would like to do so. It's totally up to you. I really just want to give the audience a vivid glimpse into what life behind bars is like for people with serious mental illness. So I defer to you.
I'd be if you had a passage that you had marked, Laurie-Marie, I'd be happy to read it.
Well, thank you so much, because I do choke up when I read this passage, so I think you would do better at it.
Maybe I will too.
At the bottom of page 31, where you talk about your visit to Rhode Island's High Security Center and the observation unit.
And then just tell me where you'd like me to stop, Laurie-Marie. Where did you mark to stop?
The top of page 33.
Yep. Tell me the last word that you want me to say.
Toy.
Got it. Okay. All right. Hello, good evening. Hi, I'm really happy to be here. Thanks so much for this invitation. Very, very happy to have this robust group of participants here tonight on such an important topic and such an important discussion. Really, really pleased to be here with this panel of doers in our state and people who are trying to make the living situation better for our most vulnerable citizens. So grateful for everyone here in the midst of everything that is swirling in our world right now. And I'm happy to read this passage that Laurie-Marie marked. During my visit to Rhode Island's High Security Center, Lieutenant McClain takes me to a pod of cells within the prison called the Observation Status Unit, or OSU. The OSU is a psychiatric observation area designed to house inmates with serious mental health issues. Our most challenging mentally ill inmates, as former warden A.T. Wall described them to me. The detainees who are held here may be sent from any of the state's Department of Correction facilities when serious psychiatric concerns arise. Floridly psychotic men shout at their voices and visions. Paranoid men lash out against their cellmates. Disorganized men climb into the wrong bed or continuously disrobe or defecate in the cell's sink. Some of the men here are so suicidal that they must be watched to be prevented from hanging themselves, or they are chronically self-injurious and so must be continuously monitored to be sure they do not bang their heads against cell walls or bite their own limbs or tear into their own skin. The OSU is arranged in a line, a small number of cells facing an observation pod so that the COs can look into each cell at any moment, 24 hours a day. The men held here are single-celled, solitary confinement for psychiatric rather than punitive reasons, though of course the effects of isolation are indistinguishable even when the motives differ. The officers stationed there point out different men to me who are behind the thick, clear windows of their metal cell doors. That's a guy whose water we have to limit, an officer tells me, gesturing to one cell. He was trying to drink himself to death. Then that guy over there ran his wife over with a car, he says, gesturing to another. I look through the window and a man stands in the doorway rocking back and forth and laughing to himself. He doesn't speak any English at all, the officer says, not a word. Then there's this guy, a lieutenant on the unit says, pointing to a young, heavy-set man with what we in medicine would call dysmorphic features, an asymmetrical, atypical facial structure that can indicate some kind of underlying genetic anomaly. He's mental health, but he's also mentally retarded, the officer says, using the archaic term for intellectual disability with sympathy and without any trace of malice. He's basically here for his own protection. Other inmates would tell him how terrible he was, and they'd convince him the only thing to do was hang himself, that ending his life would be the only way to solve his problems, and that his family would be better off without him. Then he'd try to do it, and they'd rush in and rescue him, be the Good Samaritan. Because of that, they'd get a reduction in their time. He curls his lip in disgust. They used him as a toy.
Thank you so much, Dr. Montross. It's really tough to read that, but I really feel grateful for having this window into what our prisons and jails are like. I can't praise your book enough. I've really enjoyed reading it. It's so eloquent and insightful and heartbreaking at times. And it really paints a vivid picture. So the book again is called Waiting for an Echo, The Madness of American Incarceration. And you touch on so many facets of the criminal justice system. You talk about how our country's current prison model makes mental illness worse. You talk about how correctional officers suffer greatly from the psychological toll of working year after year in a contentious, dangerous, and sometimes violent environment, and the high suicide rate of correctional officers. The book also touches on systemic racism and white privilege and the disproportionate representation of people of color in our prisons and jails. It touches on the injustice of mandatory minimum sentencing. And of course, it talks about how I would classify it as society's indifference to how we let people with very serious mental illness languish in these prisons and jails. And I do not blame prisons or jails for that, because they have to take who is sent to them for that. I blame a lack of housing and community services that allow individuals with serious mental illness and other disabilities to have contact with the criminal justice system in the first place. So my first question for you, Dr. Montross, is, can you talk a little bit about what you do in the prison system as a psychiatrist and what you mean by trans institutionalization?
Sure. So my primary job is as an inpatient psychiatrist at Butler Hospital, which is a beautiful freestanding psychiatric hospital, and I believe really does provide therapeutic care to the patients that are held therein. I work on what are called the intensive treatment unit. So these are the psychiatric versions of the ICU. So patients who are psychotic, who are very manic, who are extremely depressed, actively trying to hurt themselves or others. And what I found several years ago, I've had that job and I love that job, and I've held that job now for about 11 years. And several years ago, I really noticed the pattern that so many of my patients came into contact with the legal system. They came in contact with police, and they came in contact with our state's jails and prisons. And I began to think about how my patients struggled in our communities. They struggled sometimes even in the therapeutic environment that is really intended to help and help them and keep them safe. And I was really upset to think about how they would suffer in our correctional environment. So I wanted to learn more about that. So I started doing competency to stand trial evaluations in our jails and prisons. These are pre-trial detainees, but so they've been accused of things, but have not been found guilty of any crimes. And their public defender or their judge has raised a concern that they're mentally not capable to really participate in the court proceedings. So you're absolutely right that what I found when I entered into the jails and prisons was not only that these environments make mental illness worse, but that they also are psychologically damaging for everyone that we hold in these environments. And one of the things that I really became aware of is that as a society, I think we don't really want to think about what we do once people are behind bars, that we have this sense that if you've done something wrong, then it doesn't really matter what happens to you when you're in that environment, because you deserve to be there, so you deserve whatever you get. What I found so often was that my patients were there not because of criminal intent, or not even often because they'd done something really terrible, but very often because of undertreated symptomatology. So they were shouting in the Starbucks, or they were charging through TSA, believing that they needed to get on a plane to save the world, or they had some kind of behavior or symptom or belief that really caused them to fall outside of our social expectations for people's behavior. And in those moments, police are called. So that's one example of the criminalization of mental illness, when people's symptoms are undertreated and they behave in ways that contradict our social norms, police are called. But this question that you raise of trans institutionalization, you mentioned at the top of the seminar that there was a period of time where our state hospitals around the country ended. And this really began with the passage of the Mental Health Community Centers Act in 1963. In the 60s, 70s, and 80s, people really were shifted for altruistic reasons out of these draconian facilities and into our communities. But for the most part, the funds that were promised to be allocated to the communities to provide outpatient care, to provide housing, to provide services to these people that had required such a high level of care, those funds never materialized. So suddenly you had seriously mentally ill people sleeping in doorways, sleeping in parks, begging for food, not able to access their medication and treatment. And with this, the criminalization of mental illness really began. And we started seeing this shift in a curve from people who were hospitalized. That shift really went down, but there was a parallel shift of the people who were incarcerated, and that went up. And so the reason that we use the phrase trans institutionalization is that, yes, people were deinstitutionalized from our therapeutic facilities, but they were merely shifted into a different kind of facility, a punitive one. And when you talk about the need to be in the least restrictive environment, of course, that's not the case when we put someone behind bars.
Thank you so much. I really appreciate that explanation. Anyone else would like to chime in? Okay. Meg, this next question is for you. The question is, what is an Olmsted plan? And can you speak to the intersection of incarceration and inadequate housing options for people with disabilities, be it serious mental illness, intellectual, developmental disabilities?
Yes, thanks, Laurie, and thank you, everybody, fellow panelists and the audience. Thanks for being interested in this topic, because that is one way that we can solve problems, by so many people being interested in this. So what is an Olmsted plan? As Laurie said, in 1999, the United States Supreme Court ruled that unnecessary institutionalization of people with disabilities violated their rights under the Americans with Disabilities Act. It's discriminatory to keep people in an institution if they don't need to be. So what an Olmsted plan is, essentially, it's a framework for how a state intends to comply with this obligation to provide people with care appropriate to their needs, but in the least restrictive setting available. Currently, Rhode Island not only lacks a Olmsted plan, but we lack an array of sufficient services in the community. I think as Dr. Montross touched on, and as Laurie spoke about, we don't have a sufficient array of services in the community to treat everybody who needs treatment. While Olmsted plans address all disabilities by specialty, what I'm going to talk about is serious persistent mental illness. So what we lack here, as I said, the state lacks kind of a roadmap or a plan as to how we should be providing these services and along the continuum of care. There's initiatives here and there, and there's good ideas here and there, but we don't have any coherent, cohesive state plan, so that a lot of people fall through the cracks, and as the doctor said, they end up incarcerated and criminalized because of untreated symptoms of their mental illness. So as to the interaction of incarceration and inadequate housing options, housing is essential. As we all know, housing is essential for good health, whether it be mental health or for physical health. Housing is essential. And inadequate housing is certainly a huge part of the reason why so many people with serious persistent mental illness face incarceration. There are a lot of other factors that go along with our inability or our failure to have an Olmsted plan or any kind of a plan that also lead to criminalization of mental illness. As I said, what we currently lack is a robust and sufficient array of services in the community. And what I mean by that is that people go in and out of level of their need for care. Sometimes people are fine with just outpatient treatment, maintenance in the community, and they can live in their own apartments, and that's fine. But then there are other levels of care that people come in and out of. We need assertive community treatment here in Rhode Island. We used to have a very robust system of assertive community treatment, mobile treatment teams that were able to keep people in the community and able to supervise them to the level they needed to be supervised. For various reasons over the last 20 years, that has essentially ended. While we do still have assertive community treatment teams at the community mental health centers, they don't have enough capacity for as many people that need them by any stretch of the imagination. We need group homes. Some people need that level of care. Some people need assisted living or supervised apartments where they can live on their own, but they have case managers to help make sure that they stay on track, that they're getting to their appointments, that they're taking medications, that they're able to attend to their activities of daily living. Some people need assistance with that. A serious lack of our array of services in Rhode Island is that we do not currently have any psychiatric nursing homes to deal with the needs of people with SPMI who are becoming elderly. As we know, just because you become elderly and might need a higher level of nursing home care does not mean that you no longer have schizophrenia or bipolar disorder or other SPMIs. But we don't currently have any facility in the state of Rhode Island other than Eleanor Slater Hospital, which is able to provide psychiatric care specific for geriatric patients. There's also a big problem is that there's a lack of sufficient reimbursement for the community mental health centers that provide the treatment. The rates are so low that there's trouble retaining psychiatrists. They're stretched thin. There's trouble retaining a workforce because the reimbursement is certainly not what it needs to be in order to keep the level of staffing and the level of treatment for people in the community. Another problem that we hear about in the news all the time is the lack of an alternative to respond appropriate to a person who is in crisis, other than calling the police. That's how so many people end up incarcerated. Because we don't have a system to respond appropriately to mental health crises, then that leaves it to the police to respond. The police are not trained for that. The very presence of police officers in uniforms with weapons often exacerbates the symptoms that a person, in my experience, that a person is suffering from that leads to the crisis call in the first place. It leads to a person who really needs medical care being arrested. And a lot of my clients, a lot of who I serve are people who Dr. Montross sees to do competency evaluations, people who are held at the ACI for evaluation. They've been arrested, and this is a pattern that I see several times a week, and I'm sure there's more than what I see. But police are called, there's a person in crisis out in the community, yelling, acting inappropriately, maybe scaring people because they're acting erratically, or they're walking in the middle of the street, or that type of thing. So the police are called because that's who's called to respond. And then what happens from there is that the person gets more agitated or upset, and they end up getting charged with disorderly conduct. This is the triumvirate of what I see. Disorderly conduct, resisting arrest, and simple assault on a police officer. Those are the charges. They're misdemeanor charges, and if any person who wasn't in crisis was charged with those types of misdemeanor, low-level crimes, they would probably be set personal recognizance bail once they got in court, and they would be released. But over my years, both as a public defender and now as the mental health advocate, what I see increasingly is that judges tend to hold people for evaluation for their own safety. Whereas it might be appropriate for a person who appears in a courtroom, who's in crisis, who's very symptomatic, it might be appropriate for that person to be involuntarily committed to an acute care hospital out in the community. My observations over the years are that the judges are reluctant to do that because of the lack of array of services, the lack of proper discharge. So you have somebody who's sent to one of the community hospitals who's in crisis, they get stabilized, and then they're discharged within a week, right back to the same situation that they started in, because we don't have proper placements for people. We don't have hospital step-down units for somebody who's stabilized and might not need long-term hospitalization, but who can't go back to the homeless shelter and be expected to attend to their own needs and make their appointments and keep on their therapy and medications. So a big problem that we have that leads to this is that the criminal justice system is often the only gateway that people have to get engaged in treatment. Family members are told you have to charge people, you should charge your loved one with simple assault or with disorderly conduct because the judge can order them into treatment. And when the judge orders them into treatment, there's the mistaken belief that that's the way that you get people to comply with treatment, or you get people to understand that they need to be in treatment. And as we know, through the criminal justice reform and through studies that have been done, we also have a problem of the overuse of probation in Rhode Island, not only the overuse of probation, but for lengthy periods of time. So a lot of people who end up getting caught up in the system, they're on probation for something from years ago. They're in crisis in the community, and any little thing they do triggers a probation violation, which pretty much automatically gets you held without bail at the ACI for 2 weeks. So these are the problems: the lack of an Olmstead plan, the lack of an array of services that leads to incarceration of people. And I think one other thing that's important that Dr. Montross touched on is that I think judges, very well-meaning, want people to be evaluated, want them to get into treatment. But I think what we lose here is that you're taking this very sick, symptomatic person, and they're not going right to the forensic hospital to get evaluated. They're going to jail. They're going to the ACI, where they end up in the OSU or in, solitary confinement while they're awaiting a doctor to be able to come and do the evaluation. And then a lot of times, even if a person is competent to stand trial, that's a legal term, not a medical term. You can be competent to stand trial, but still very, very sick. And those people don't get transferred over to the forensic hospital. They stay in prison. So there's just a number of factors that play into this.
Thank you so much, Meg. I was struck by something you said, and Dr. Montross's book touches on this as well. There's such a thing as a compassionate arrest, where a police officer knows that a person faces a greater danger being on their own, living on the streets, and therefore they arrest them for their erratic or disruptive behavior, just to simply give them a place where they'll have shelter and food and bed and some treatment for a period of time. Does anyone else want to speak to what Meg was saying? Dr. Montross, and then Brenda.
Well, Brenda, why doesn't Brenda go ahead? Because I had my turn, and then I'll follow up. So go ahead, Brenda.
Yes, I appreciate being able to speak at your meeting, and I appreciate all of your professionalism. So being a person who does have a mental health disability, I've suffered 20 years of addiction to crack cocaine. I've been everything under the sun that pertains to addiction. I've been through all the institutions, all the jails, all the prisons, pretty much between New York, Connecticut, and Massachusetts. I found recovery here in Rhode Island, and the only reason I was able to finally get healthy and wellness is because I took the faith-based route for my treatment. All the institutions, jails, hospitals, rehabilitation centers that we're speaking of that are improperly discharging people, I think they're all right here amongst us. And since I've been clean and sober in Providence, Rhode Island per se, I've been rescuing people from the streets and bringing them into some of the hospitals that have been named here. I'm not going to try to condemn anyone or name any particular hospital, but even right now on my caseload, they're improperly discharging their patients. They're blocking the individuals that are trying to keep them from winding back up in patient hospitalization. They're blocking us from meeting the patient at the door at discharge. It's almost as if the individuals involved in the process are participating willfully, knowingly. And we had a person who discharged recently from one of the hospitals here in Providence. The person had a serious conviction and was a threat to the community and was living under a bridge. And the only reason we were able here at OpenDoors to get him to where he is living healthily, not homeless, and everything else that we have him right now doing is because of the fact that we have people who have the lived experience here to help him. Now, those of you who have the degree, I'm so impressed. I'm trying to get to where you are with my professional development. But what good is it if you're letting the people discharge from your very institution? I just had to go track down someone's property. Like the people that are on the floors that these individuals live on don't know anything about the property that the people have to discharge with. They come in with suitcases with everything they own and leave. And then the nurses say, oh, we don't know anything about that. We don't have anything to do with that. That's harmful to an individual that's discharging. So I just want you to realize, you know, it's kind of difficult. I'm gonna be honest. It's difficult to sit here and listen to people who are in charge. You're in charge. You have a say. I know you don't want to risk your job, go against the grain at your jobs and whatnot, do the best for your career and your family. But a lot of the people are falling through the cracks simply because they're not getting the services that they're supposed to at discharge.
Brenda, thank you so much for sharing your story. And I'm so glad that you're doing well and you're healthy now. And I really admire you for never giving up and for fighting for yourself. I'm so glad you're here tonight too.
Thank you.
Dr. Montross, did you want to add anything?
Well, just quickly, and I will say, I think we're here tonight because we share Brenda's concern. I think that we feel as though the treatment options available for people here are inadequate. And so we're here, I think, standing with you in that desire. And I think one of the things that really shows that our hospitals also are not meeting the need is this idea of compassionate arrest. You know, police will sometimes say they take someone to the hospital and the hospital says, we don't have any beds, or someone's admitted and then very quickly they're discharged. And then when the police are called the second time, instead of taking them back to the hospital because that didn't work, they take them this time to jail. And I think that this key question of why legal response is the response we permit for mental illness is a really critical one in this moment. That why are police first responders to psychiatric emergencies? We don't call police when there's a motor vehicle accident. We don't call police when someone's having a medical emergency. We have EMTs and paramedics that show up that can start an IV, stabilize a fracture, stop bleeding. And we should have similarly trained clinicians show up instead of police in those moments of mental health crisis. And similarly, this idea of compassionate arrest, we would never arrest someone to be sure that they got their chemotherapy. We would never arrest someone to be sure that they got treatment for their diabetes. This is only something that we do to people with mental health issues, and that's unjust.
Thank you, Dr. Montross. Anyone else want to add to that? Brenda, please.
So as it was stated earlier, I'm a social work major at Rhode Island College, and they send us out on assignments at the local hospitals, institutions. I had to find a social work clinician at a hospital and interview her. And she just so happened to be working in the discharge portion of her hospital. And the individuals that were in the hospital because of addiction and or mental health, those were the ones I was most concerned with because of my personal experience. I asked her if she knew of the facilities she'd be discharging individuals who needed further treatment from the hospital. If she could name the facilities, she couldn't do that.
Yeah.
I think if I can just add really quickly, I think that, and I'm sorry if you can hear my toddler in the other room, you know, working at one of the hospitals that has been referred to, I feel some level of responsibility to, you know, to speak up. I think that one of the things that strikes me about our big systems problems, whether it be homelessness or folks with disabilities, folks with mental illness, is this inability or unwillingness to take responsibility as institutions, right? Like we're constantly passing off responsibility to other institutions. You know, the hospitals say it's not our responsibility to make sure that people are housed when they discharge them. You know, the folks at the Department of Corrections have the same problem, right? Like they can't create housing for the people that they're discharging from the prisons. The folks who are providing homeless services can't, you know, magically get the state to invest in housing. And I think all of this really speaks to that original question of the need for some kind of plan, right? Like a state level, how do we address this issue? Because because for as long as there is no plan, everybody is, and in some ways, understandably, focused on what is my mission. How do I do my mission with the funding that I have, and then like call it. And so with no kind of guiding mission or values as a state or as a community about how we want to take care of each other, that I think will just continue to happen.
Yeah. And, I just want to say sort of in line is that I appreciate when Brenda does make these issues personal, and when she does also ask for accountability, because it's very easy in conversations such as these to say, like Sarah said, you know, we're all doing our best. And so thus everyone is blameless. When in fact we are all blameful, and it is important, or it is shorting, you know, the people's pain and suffering when we just sort of forgive everyone across the board that way. So yeah, just want to add that.
Nick, to that, I will add that we are long overdue for some kind of a plan, whether it's an Olmsted plan or community integration plan or whatever we want to call it, but we are long overdue. People have been languishing in prisons and jails for far too long across the country and here in Rhode Island. And I think we all need to get good and angry about it and, you know, really put our voices together to do something. Mental Health Association is working on a policy proposal around an Olmsted plan, and I would love to have as many signatories as possible on this proposal. And I want to include as many voices as possible in this proposal to make sure that we're meeting the needs of all of these groups of people who have been hidden away for so long and left to fend for themselves. Because I feel that those of us who do have a voice and do have the ability to speak need to do so. I feel like it's our moral imperative. And that's why we're here tonight, because we want a plan. We want this, we want to break this cycle. Brenda, the question. Oh, sure. Please, Megan.
I'm sorry, there was just one thing, maybe we can get back to this later if we have time at the end of the program, but one thing I did want to mention as part of this state plan that we all agree that we need, and part of the array of services is, as many of you probably or may have heard, the state currently has a plan to close Eleanor Slater Hospital, essentially, which is the hospital that provides long-term care and treatment for a very small percentage of the population that needs long-term hospitalization. And the state is currently proposing a plan that will close all psychiatric capacity, not for the forensic unit, not for the people who are criminally involved, but for everybody else, to close Eleanor Slater Hospital. So that is that's scary. That's something that we all need to be aware of, because we do need some capacity for the state to have long-term residential treatment for people with the most severe and most persistent and most treatment-resistant illnesses that need care. So maybe we can talk about that more later, but I just did want to add that that is an essential part of this array of services that we need. And if they want to discharge people into the community, which is what they're saying, as people have the right to live in the community, we need to have this plan, and we need to get this infrastructure into place before anything like that could even be considered. So thank you. I just wanted to make sure I got that in there.
Thank you, Megan. I think that's really important, and I'm glad you brought it up. You're right that an Olmsted plan would provide for the full continuum of care, you know, from the lower levels of care at the outpatient level all the way to long-term hospitalization and housing options for people with disabilities. Brenda, the next question I have is for you. How does the criminal justice system currently respond to people with mental health challenges? And what are some of the ways that the process could be improved? Please feel free to elaborate on that. You're on mute.
Okay, I'm so glad you asked me that at this point, because Miss Megan Clingham had just made mention of Eleanor Slater. I have a client on my caseload right now who is in forensics at that facility. And I am aware that, you know, talks are looming about that facility closing. That person does not appear to be able to live in our housing at this time. But the nurse is actively working to place her here or anywhere else she can. And it is disheartening because the individual does not, to me, appear to be able to discharge quite yet, at least not to our facility. But as it pertains to your question, when you have a mental health illness and you come to jail, you're treated not even like a number. You're more like an object. And I've been incarcerated a lot. I can give you one example. Whenever you go to jail and you have a mental illness, it's most likely that you have been there already. So the psychiatrists in the facility already have files on you. You just get right back onto the medication that they're willing to give you. They wake you up very early in the morning, 4:30 in the morning for breakfast. Medication lines, it's like cattle. You're herded around like cattle. I would like you to know that I was in and out of jail because of drug addiction. I've never harmed anyone or murdered anyone, but being in mental health facilities in the prison system, I've been, for instance, in a cell with a woman who chainsawed a man, and my bond was $50. I needed $50 to get out. I was in there on a prostitution charge, and I was in a cell with a woman that chainsaw massacred a man for drugs and had like millions of dollars for a bond. This is the way they treat you. It does not matter what your charge is. It doesn't matter why you're there. It doesn't matter how long you're going to be there. If it's possible for you to get out, they're going to put you in a cell with someone that is very likely to cause further injury to your person. And that's just how it is.
Thank you for sharing that, Brenda. I'm so deeply sorry that you had that experience. Dr. Montross's book touches on that issue, that many of the people who have serious mental illness and end up in jails or prisons are there because they can't simply afford the bail, even if it's just a few $100s, or in your case, $50. And so there's this great injustice where people are incarcerated, they haven't been convicted of a crime, they're there before their trial, and they're treated like everyone else who has been basically convicted. Dr. Montross, do you want to elaborate a little bit more on your own experience witnessing that?
Yeah, I mean, you're exactly right, Laurie-Marie. You know, the once you're in jail, they treat you the same, no matter why you're there. Once you're in prison, they treat you the same. So whether you've committed a terrible violent crime, or you're there for a drug charge, or you're there because you're mentally ill and your symptoms were poorly controlled, it doesn't matter. You're treated the same way. And I think it's important to say, we are treating people the same way, right? Getting back to Nick's point about responsibility and culpability in this, when we vote tough on crime, this is what we're voting for. We are voting to send people into these places. And when we say we don't want funding for rehabilitation, we don't want funding for job skills training and education in prisons, and we take those things away, we are the ones who are causing this. So we have responsibility in these policy decisions that we really need to own. I think the other thing that Brenda brought up that is really critical, and it kind of goes along with this idea about the division between how we view mental health in a different, lesser than way than other illnesses, is when Brenda's talking about crimes of addiction. Addiction is a disease, right? Addiction is a disease, and we have chosen to treat it like a crime. We don't have to choose to treat it like a crime. So the other reality is that there are enormous numbers of people who are languishing in our correctional facilities because they are ill with the disease of addiction. And we as a society have chosen, when you talk about criminalization of mental illness, we have chosen to call that a crime. We have the option not to do that. We have the option to say all the money we're spending on incarceration, which by the way is an enormous amount of money, we could instead be putting to treatment for people so that our response is different in those instances.
Please, Nick. Thank you.
I wanted to tell a story that I think illustrates one of the more extreme versions of this problem, because I think it's important to, once again, get back to the idea, yeah, this problem does belong to all of us, and it is one that everyone is struggling with. On the other hand, there are instances within the system where it is patently just unjust, fraught with immorality, and it has been distorted to a point, almost beyond recognition. And that is a fixable problem, right? Not all these problems are, we just need more resources that don't exist. So back in, for about 2006 to 2010, our agency worked on a campaign to change the probation revocation laws in Rhode Island, because if someone is on probation, they can be charged with a new crime, incarcerated, and ultimately have those crimes dismissed, or be even found innocent, or be acquitted. This is the way the laws were at that point, and still be sentenced for that incident, right? Because of the way that probation revocation works. So there was one case that was sort of brought to my attention during this time by someone in the public defender's office. They were working on an appellate case for the individual, and he was someone who was seriously mentally ill. And one day in Newport in 2006, he was sort of harassed, got into a back and forth with a bunch of kids, like teenagers, who were giving him a hard time. They, according to the court record, sort of mocked him and threatened him. And at the end of the incident, he threw some pebbles at one of them and hit them, and no injuries were caused. And this individual was released on probation and serving a lengthy probation sentence for previous B&E. Once again, an incident in which no one was hurt. He entered a house of someone he knew during the daytime. And he was ultimately, in the probation revocation process, he was sentenced to 5 years in prison, and the misdemeanor assault charge was ultimately dismissed. And it was just this distorted system we have of probation violations, and that the lack of due process that was afforded to him in the probation violation hearing, the fact that ultimately the charge itself didn't matter, that he got this extensive sentence, and as someone who, once again had serious mental health issues, was then put into the prison system for a number of years, where he ultimately ended up in high security, right? And this was right, all sort of touched off by an incident which didn't need to lead to his arrest, much less his incarceration. And so situations like that certainly shouldn't happen. We were able to make some changes to the probation laws during that time. But I can't say that the same thing wouldn't happen right now in our courts today.
Thank you, Nick. Nick, I have a follow-up question for you.
Yeah.
Based on your work with people being released from prison, how are they discharged? How are they referred to resources in the community? What waits for them in the community?
So yeah, want to talk about how the problems that exist, or in some cases are exacerbated or created within the ACI, then become the reality that we in social services, we in reentry deal with on a day-to-day basis. So there is some ability to provide sort of a minimal level of discharge planning support. There's a mental health discharge planner who's wonderful, and does her best to line things up for people and make sure that they have at least prescriptions when they're on their way out the door. But obviously it's really insufficient because of the fact that they have spent all this time in prison, not only not getting sufficient treatment, but in many cases, right, having the mental health problems made much more severe. So there's as a result, right, the problems that then show up on the doorstep outside the prison are really insurmountable. So There's one individual, once again, to sort of talk about a story. Well, I guess two stories. One that sort of touches on the situation in prison. When we were running some classes in prison years ago, there was a student of mine who sort of wrote the most compelling essay of the sort of get to know you essay at the beginning, sort of about his relationship with his mother. And he was just really creative and a bright guy. And he was serving a lengthy sentence. He had gone in at a very young age. I think he was serving a 10-year sentence, and had some very severe anxiety issues, and was on medication for those. And ultimately the way that the prison system deals with and responds and sanctions people is just very likely to exacerbate the problem. And ultimately this guy was going to get out, and society was going to he was have to deal with him. But what ended up happening is that he got in trouble because he was distributing his medication to other people in the prison, and he ended up going to segregation for about a year, and served a significant amount of that time in high security. And by the time he got out, right, he had his just whole psychology had transformed. And I guess I point out to that story because that was a moment when it really seemed to me like there were things that could have been done to prevent him from going to segregation. And instead, the sort of system responds in a way which is, how can we punish this instead of how can we prevent it? So I just remember sort of asking people, like, why weren't they just like crushing up his pills? And then he couldn't have sold them. And if there were just a thought process towards mental illness that was looking towards how can we decrease these behavioral problems, then they might be some of them might be avoidable. And I understand a lot of them aren't. But that was just a person that I cared a lot about, and it was hard to see him end up in high security for so long. Because then when he got out, I remember going and talking to him and trying to help him, and he was just there was really no chance. He just ended up right back in. He relapsed and he went right back in, and now that's going to be the rest of his life pretty much. He's a young guy, and there's other individuals that we've been working with for years that have much more very severe cognitive problems and mental health diagnoses, schizophrenia, bipolar disorders, and they're really just there is no place for them. So the way that the prison system is set up, they're spending large amounts of time in solitary confinement and high security. I do think it's worth talking a little bit about both of those systems in depth on this call, because they end up as the locations for so many mentally ill people in this state. So my understanding is that the DOC estimates that about 20% of its population is identified as having severe persistent mental health issues, and that about 100 a year of these people end up in solitary confinement. And so just sort of thinking about what that means, and the fact that there's this entire building at high security that is sort of dedicated to the last resort of dealing with these problems. And it's ultimately totally inappropriate, for the challenge. Yeah. I don't know. I guess I'd love to. I know that Dr. Montross has spent a lot of time in that facility, but and also with investigating sort of both of those situations, solitary confinement and high security. But I think I'd love to talk about them a little more, because they ultimately are sort of the places that are people are being released out of onto the street.
Okay. Thank you, Nick. I really appreciate that. We will pick that back up shortly. I wanted to ask Sarah a question about racial disparities. Can you speak a little bit to the role that systemic racism plays in the disproportionate number of people of color who also happen to have one type of disability or another, mental illness or intellectual or developmental disabilities, and how they are overrepresented in our prisons and jails?
Sure. Yeah, so this is obviously an enormous issue that we could talk about for a long time. It's far more complex than we can fully address here. We could talk about how Black kids are more likely than their white peers to be incorrectly diagnosed with a conduct disorder, like a behavioral disorder, before ultimately being diagnosed with autism spectrum disorder. And that obviously has significant implications for how their behavior is treated in school and potentially their entrance into the juvenile justice system. We could talk about the impact of poverty on mental illness, since of course people of color are disproportionately living in poverty in this country, including the impact of community violence, right? So I've always found it really interesting that we, in specific cases like with veterans or women who've experienced intimate partner violence, we consider PTSD and the experience of trauma as a mitigating factor in criminal cases, right? But we rarely talk about the trauma of having witnessed community violence. We could talk about behavioral health care access issues in the community. So despite having similar rates of behavioral health disorders, people of color are far less likely to access behavioral health services and treatment. In fact, 69% of Black Americans with a mental illness are not in any form of treatment. And we can talk about what kinds of racial disparities exist in regards to how we treat people with mental illness once they're actually in the criminal justice system. So we've talked a little bit about restrictive housing or solitary confinement today. And I think that that's actually a good example. When we talk about solitary confinement, we're talking about being confined to yourself for 22 to 24 hours a day. And so we know that Black people and people with mental illness are overrepresented in the criminal justice system. They're also overrepresented in solitary confinement. This is a national problem. It's a local problem. A study from Yale came out based on 2019 data, showing that on a given day in Rhode Island, Black folks make up 30% of the population at the ACI, but 44% of folks in restrictive housing. And among people with SPMI and restrictive housing, people of color are also overrepresented. There's the disparity that exists in the community. There's the disparity that exists in the courts and in the prisons. There's a little bit of evidence, mostly coming from a study at Rikers, showing that Black and Latino folks are less likely to receive mental health care treatment once incarcerated. And so there are, that's another place we have to look at when we're looking at racial disparity and the impacts of systemic racism on this issue. So there's a whole menu. And I think, happy to chat more about any one of those things. But I think it's hard to tackle in a short amount of time.
Thank you so much, Sarah. That was enlightening and depressing. We really have a lot to work on as a society. So we have about 20 minutes left, and we have a lot of great questions from our audience members. This first one I think is directed to Dr. Montross. Can you speak to the issue of children entering into criminal legal systems due to mental health trauma?
Sure. And I think this question dovetails so beautifully with what Sarah just laid out. Systemic racism is a fact of the world, and it's a fact of the legal system for sure. And juveniles, you see this really, really clearly among juveniles. And so kids who behave in impulsive ways, maybe have been victims of trauma, maybe have witnessed trauma. Those are kids who are likely to act out. And often those experiences are under-recognized, and they're less recognized in kids of color than they are their white counterparts. It's also important to recognize that, that at every level, kids of color are treated differently than their white peers in the juvenile system. So Black kids are more than twice as likely to be arrested than white kids in the first place. They're less likely to have cases diverted away from the judicial system. They're less likely to get probation instead of jail time. They're more than 4 times as likely to be committed to a juvenile detention facility. So when you're talking about kids that may have come from communities with trauma or families with trauma or environments of neglect, as we know that our citizens of color are more likely to be overrepresented in those kinds of circumstances due to economic disparities, that we know that we're shuttling people to these places wrongly. There was a really stark example of the of racism in sentencing of juveniles. That was this study that came out of Stanford. So before 2010, it was actually constitutionally fine to sentence children to life in prison without the possibility of parole. In 2010, the Supreme Court finally said that we couldn't do that any longer. But prior to that, Florida led the country in sentencing juveniles to life in prison without the possibility of parole. And 84% of the kids who got that sentence were African American, but the population of Florida is 16% Black. So exactly what Sarah is describing, this real disparity was true there. The Stanford study took a group of 700 white people, because white people are overrepresented in the judiciary, they're overrepresented in the legal field and in jury pools, and they told them the exact same story about a kid. This was a Black male this was a male with 17 prior juvenile convictions, 14 years old, and he was accused of a brutal crime. They changed one word in the study, and half of the recipients had him described as a Black male, half of the recipients had him described as a white male. And those who read about a Black juvenile expressed significantly more support for life sentences in prison without the possibility of parole than those who read about a white boy. And they also were more apt to say that juveniles have the same responsibility as adults do in criminal cases, just those who read about the child as being a Black boy as a white boy. So I think these issues are connected. I think trauma and mental health are really deeply connected to what Sarah was talking about, and it's critical to consider them together. And it's critical to our understanding of childhood and neurodevelopment to say that kids who are traumatized may act out in ways, and we have to recognize that not as misbehavior that needs further punishment, but that as symptoms that are in need of care.
Thank you so much, Dr. Montross. Anyone else want to chime in? Meg, this question is for you. What do you see as the role of peer specialists, people who are living in recovery and who support their peers, in the staffing issue you mentioned, either at mental health centers or in peer-run organizations? And Brenda, Charlie would be interested in hearing your point of view on this as well.
I think peer specialists are essential as part of our array of services. And I think that over the since I've been around, so many years, we've gotten a lot better, and we have a lot more representation of peers. Just from speaking with my clients, I know what a difference it can make if somebody who's in crisis, say in an emergency room, is connected with a peer specialist right at the very beginning of their treatment. It can make a world of difference. And I think that we need to do more to enable peer specialists to be at every level of treatment. You know, at every level of treatment, not just in the emergency rooms, in the community mental health centers, but at hospitals, at all levels of treatment. So I think that's huge. And I think there's a lot of research and also a lot of anecdotal evidence that can make a huge difference in somebody's recovery process.
Thank you, Meg. Brenda, do you want to add anything to that?
Sure. I think it's absolutely critical. And all the abuse that we're hearing about women and people of color, that we experience inside and outside of jails and institutions. All that we go through. Once individuals are discharged, a lot of times right now in the state of Rhode Island, women have nowhere to go. There's nowhere for us to place women. It is an actual crisis that's being swept under the rug. I feel like that's the best thing someone being discharged from jail, especially a woman, can have, someone that has that lived experience. You have to have a certain amount of savvy to navigate a society that's not welcoming to an individual who has made the decisions or has fallen victim to the clutches of addiction. A lot of this is not by choice. It comes to the point where addiction, in the addictive lifestyle, you've lost your choices. So, let's not be fooled. There have been times throughout my life when I preferred to be in jail because it was safer for me. I could get a certain amount of medical care, get off the streets for a little while, if you will. But here in Rhode Island, there's nowhere for women to discharge to. And I just hope you guys realize, the seriousness of that. One time, I'd say about a year ago, I had a friend that I brought to Butler Hospital. I went in there to visit him. There was a woman out of her mind that I recognized from the streets of Providence. Right now, she's still running around in the streets. Like, what's going on? This is a public health emergency that each and every one of our public officials is driving past this woman and sees she's out of her mind. She's not safe. It's a public health emergency, and it's just being swept under the rug.
Brenda, I'm so glad you framed it that way, as a public health emergency. I agree for sure. I agree 100%. I think this has gone on for too long, and I think and I hope that those of us here tonight will band together and demand an Olmstead plan, and demand that we actually fund the Olmstead plan, because that's the real challenge, is having our state designate permanent funding streams to support the resources, the housing options, the community services, the peer support specialists, to help people who are struggling on their own. This is a question for Dr. Montross and for Megan. Can you please speak to the issue of fatigue displayed by community hospitals and providers, judicial officers, prosecutors, probation officers, and correctional staff when interacting with high utilizers of the mental health system and criminal justice system? It seems like they frequently see relapse, either psychiatric and or substance use related, as an inability for individuals to get needs met in the community, and they rely on the criminal justice system as a last ditch effort. So can you speak to that fatigue? Maybe it's compassion fatigue, where, as we've talked about, we're turning a blind eye to this.
Megan, I've talked a lot. Do you want to take this one?
Sure, I can start. Yeah, I do. A lot of what I do is interacting with police departments and providing some type of training for police officers and crisis intervention techniques, that kind of thing. And what I hear from police officers a lot is that just what you're saying about the fatigue. We know this guy, he's on the street all the time. We bring him to the hospital, and then within 5 hours, we see him walking down the street again. And out of that frustration, fatigue, frustration, whatever, they arrest the person. And yeah, I think that there's a really lack of, I don't want to say lack of empathy, but a lack of understanding that people are not choosing to live lives on the street in misery. That's not a choice that people are making. And I think that's something that people need to understand. And, we all get fatigue. It's hard. It's hard what we do. And I know, I can only speak to my own experience as in this, my little part of the cog in this wheel, but it is fatiguing, but we can't let that make us lose our humanity and see people as a person who's not making a choice to live the way that they want to, the way that they are, just because they feel like, living on the street under a bridge, unmedicated. That's not a choice that people are making. And I think that's something that's often lost when you deal with people in crisis all the time, and particularly people that are not, I don't mean to keep saying police, but particularly people that do not have the necessary levels of training to understand the people whom they are serving. And
I also think that going back to a point that Nick made earlier too, or to piggyback on that, I think that we also it's easier to ascribe failures to people than to our systems. And I think that oftentimes when people are recurrently coming in contact with the legal system, recurrently utilizing the hospitals, this is because we are not serving people in a way that keeps them out of crisis. And I think, Laurie-Marie, one of the really critical pieces of an Olmsted plan, as you're talking, is that the goal is to keep people out of crisis. And oftentimes people will say the only time they can get services is if they're suicidal or homicidal and get admitted to the hospital, or they end up in jail. And really that's, again, to draw this parallel to different forms of medical illnesses, that's like saying to someone with high blood pressure, we're only going to treat your high blood pressure when you're having a stroke. In that case, come to the emergency room and we'll treat you. But otherwise, we're not going to give you, the $4 medicine that's going to control your blood pressure for a month. And so I think also one of the things that happens is that people are recurrently coming in contact with these crisis systems because we as a society are not doing a good job at providing the resources necessary to keep people out of crisis. So that's on us.
Can I add, I want to also put some focus on the evidence we have that this is possible, right? That this isn't all just sort of a hopeless series of untreatable illnesses, but that if we did have a form of treatment in place, like Dr. Montross mentioned, that if we were actually creating institutions that can treat these problems, then we could prevent people from cycling through the criminal justice system in the way they are. And I can speak, from my experience when we've worked with people who really there are no alternatives in the community that are created to properly support them. There are no housing options that are appropriate. They sort of go into each different institution only in crisis, and it fails them. And they're really, we are sort of trying to cobble together with the minimal amount of resources that we have, some sort of system where we can, put someone into a recovery house that, is like we were literally trying to figure out how to find a place for a client of ours who had been released from high security and who was decompensating and couldn't get treated anywhere and had no place to live. Figuring out a way to have him live in our transitional house, stabilize, and stay clean. And ultimately, we have been successful in these sort of limited moments and times where this individual I'm thinking of had not been out of prison, had not stayed out on the street for more than 3 months in his entire adult life, right? And he was in his late 30s, and he had been incarcerated 32 times, I think, when I counted. And we were able to keep him out of prison for a year and a half, really without any program that was designed for him, but just by sort of trying to actually administer, some sort of appropriate level of care. And there are other examples, and I'm sure Brenda herself can talk, like, I want to laud Brenda for being, a story of hope, someone who overcame an incredible amount and now has achieved, really like has achieved so much. And so I think it's important to keep an eye on, or keep a focus on what is possible if we make some hard decisions. Because right now what we're doing is we're investing all of our focus and all of our attention into incarceration. And justice reinvestment is the idea that we need to make some hard choices about where we're putting those resources. And if we do it successfully, those resources do exist. They just need to be reinvested.
Yeah, and if I can just jump off of that, I mean, I think, right, Nick is so right. We all do this thing. We don't take responsibility for our own stuff. And we also are constantly like, oh, the problem is too big, we can't solve it. there's also some really small things we could do. And, you know, to Christine's point about how we make choices, right, as individuals and as systems, there's no reason that, you know, and again, like as somebody who works for a really large hospital system, take the heat for it, even though it's not my stuff. There's no reason we have to refuse to keep seeing people for psychiatric care when they miss some of their psychiatry appointments, right? Like, we don't need to have those kinds of punitive systems in our healthcare system to say, like, well, you've missed X number of appointments, so you can't come to this practice anymore. Or you've been difficult to work with in the past and you can't come to this practice anymore. And those are things, again, like, there's choices, those are choices that we make, and we can talk about the ways in which for those institutions and the systems, they seem like rational choices, but we have to be responsible for the outcomes. And so those are the kinds of choices that we could just choose to make differently.
Well put, Sarah. Thank you. We have time for one more quick question. Bruce is asking, there was some talk at the beginning of the year about a mental health court that would have diverted people from the criminal justice system. And then the pandemic hit and the General Assembly shut down. Has there been any movement on this idea over the past several months? Does anyone know?
I don't believe there has, because the General Assembly hasn't been back in session, and, you know, all talks of any pending legislation, to my knowledge, have pretty much stopped this year.
Well, this is something we can certainly all get behind for next year, I think. I put a link in the chat box if you'd like to get more involved with the Mental Health Association's campaign to get an Olmstead plan in our state. I put the link. You can read all about Olmstead plans, and at the bottom of the page, there's a link you can click to sign up for action alerts and announcements. Also, I would like to say, we're putting together brief videos, maybe 2 minutes long, 3 minutes long, of stringing people's faces together. Each person gets, 10 or 12 seconds to say what an Olmstead plan would do for them, their clients, their family member. Basically something like, Rhode Island needs an Olmstead plan so that my father, who struggles with addiction, can recover in the community instead of cycling in and out of jail or prison. Something very succinct like that. If you'd like to send us a video, I'll put it in the chat box. It's simply video@mahari.org. And again, the video should be super brief, maybe 10 or 12 seconds, maybe 15 seconds at the most. You can just snap the video with your smartphone and have your clients and constituents send us videos as well. We will share these videos with elected officials so that they can see that not having an Olmstead plan has a real life effect on people all over the state. And I think this will help humanize the issue and put faces to it. We'll also post it on our website and share it on social media, and you're welcome to share those videos as well. Lastly, I think I would be remiss if I didn't say that as a gentle reminder, we are living through extraordinary times. Things are really difficult right now, even for those of us who are not incarcerated. Some days I know it can feel overwhelming. Some days it feels very depressing. Just remember that it's okay not to be okay right now. If you're having trouble coping or focusing, if your sleeping or eating habits have changed, if you're feeling depressed, if you're feeling anxious, if you're feeling like you're relying on substances, please reach out for help now. Please don't put it off until after the pandemic, because we really don't know when this will end and when it will be safe again. There are psychiatrists and therapists in Rhode Island who will see you either in person, in a video chat like this, or talk to you on the telephone, whatever your comfort level is. You deserve to feel better now, so I encourage everyone to take care of your own mental health. Lastly, if you're interested in signing up for our third Integration for All town hall, That will be November 17th at 5 o'clock. You can sign up on the link that I previously sent. We will hear from staffers from other states that actually have plans in place, and we will pick their brains about how they had those plans established, how they funded those plans, how they continue to keep them alive during this economic recession, and how they've implemented the plans. You know, what are the nuts and bolts that go into a plan, and how do they actually do it? So if you're interested in that, join us on November 17th. I want to thank all of our wonderful panelists for being here tonight, for sharing your stories and being vulnerable and brave, and for participating in this. I really appreciate your time. I hope this isn't the end of the discussion. And again, please join the Mental Health Association. We will not stop until we get an Olmstead plan, and we need your help. So thank you very much, everyone. Take care of yourselves and take care of each other. Bye-bye.
Thanks, Laurie-Marie and everyone. Thank you.
Let me take that.
Yeah.